difficulties that we encounter for screening, testing, referral, initiation support, and follow-up will be starting soon. For those of you who have joined just now, please start attempting the pre-test. There is a link in the chat box. This is important to do both pre and post test. One, as you know, it has been the part of the format of the series. For those who complete both pre and post session and attend through the session, will get a certificate of participation. Even more than that, I would say this pre-test, we have taken care that we include, bring in a lot of case scenarios that we encounter in day-to-day clinical practice and at different levels of healthcare. So these case scenarios will help you understand the topic in greater depth, and it would help you in identifying the clinical variation that happens. And sometimes, we take this variation as normalization of the, way of treatment, but whether they are aligned with the standard treatment guidelines or not, it is very important to see that. So please attempt doing this. At the end, when you submit the pretest form, you can view your own scores yourself. You can evaluate yourself and find the correct answers for the questions that were marked incorrect correctly. There is a question. Is there any difficulty in this question? Dr. Akshay Gode, you've written. Meanwhile, if you have any difficulty, you can write in the chat box. We'll be looking at the chat box frequently. If possible, we will try to address these questions in the session itself. At the end of the session, you can write, you can keep your questions ready for the end of the session so that you can answer, get the right answers. Welcome, Dr. Rajendra Prasad, for joining.
Thank you, madam. Good evening.
Thank you very much for joining despite your personal family commitments and health issues. Thank you for joining. We will be starting soon. Dr. Patni is going to join us in another 5 minutes, and he will formally release inaugurate the 4th series, and then we will start with the session. In the meanwhile, we put the questions in the, we have done the pre-test questionnaires in the chat box. They are attempting doing it.
उस दिन तो जल गया था भाई, क्या जल गया? ये जला, बड़ा हल्का जल रहा, तेज भी होता होगा, कहीं देखो, तेज भी करने का होगा इसमें भैया। हाँ, हो गया जरा नजदीक करो मेरे। वैसे ये अंशिका ने बहुत अच्छा मंगा दिया था भाई।
I think from our end, there is no issue with the audio and video. Even the link of the pre-test is opening. Please check at your own end. Others have been able to open it and answer it.
ऑडियो वीडियो है कहाँ इनका? म्यूट, अच्छा म्यूट ये है, स्टॉप वीडियो ये है। Dr. Sangeeta, I'm audible?
Hanji sir, we can hear you.
Okay.
Sir, you are audible, sir.
Okay. Actually, I was in some felicitation program. People kept so I just finished it early and I came back to home.
I'm very happy to share with you all And I think you will all also join us and congratulate Dr. Rajendra Prasad being awarded Padma Bhushan this year. He was.
Padam Sri. Padma Sri, madam.
ओह वेरी गुड। पद्मश्री मैंने आपका और अपग्रेड कर दिया। नेक्स्ट ईयर आपको वो वाला भी मिल जाएगा। बट
Thank
वी आर
you.
वेरी वेरी प्राउड ऑफ हिम। he's been really very working very hard at the grassroots level, building capacity, teaching. His passion is teaching, and he spends all uses all uh, opportunities for educating, imparting knowledge, and developing the next generation. Wish you all the best, sir, and very very happy, more such accolades for you in future.
Thank you, madam. I am really obliged. We have been working for last so many years together. I hope we keep on working.
Yes, sir. We are yet to learn from you many more things.
Thank you.
रंजीत, डॉक्टर पत्नी ज्वाइन कर रहे हैं?
Ma'am, he'll be joining with us soon.
हाँ, आगे से थोड़ा टाइम थोड़ा जल्दी दे दिया करो। सर तब तक आप अपना स्क्रीन शेयर टेस्ट कर लीजिए।
अच्छा, 1 मिनट में कैसे इसमें स्क्रीन शेयर जहाँ
हाँ
लिखा
जी,
उससे
हाँ
करूँ?
शेयर वाला है नीचे जहाँ पर
शेयर करें।
वीडियो और म्यूट का है
हाँ, शेयर
बटन।
कर लिया। स्क्रीन भी मेरा आ गया।
हाँ जी, नहीं अभी करिए
नहीं,
उसको।
स्क्रीन नहीं, ये माइक्रोसॉफ्ट पावर पॉइंट ही सीधे हो जाएगा। शेयर।
हाँ
आई
जी,
थिंक माई स्लाइड्स आर
हाँ
विजिबल।
हाँ अभी लोड हो रहा है सर। हाँ हो गया हो गया, गुड।
राइट सर।
हाँ जी सर।
हाउ टू अनशेयर इट?
उसमें स्टॉप शेयर का बटन भी आएगा, प्रेजेंटेशन के साथ ही आता है।
अच्छा, स्टॉप। हाँ, स्टॉप लिखा हुआ ये।
हाँ
तो अभी तो मैं स्टॉप कर दूं, बंद कर दूं
हाँ
ना?
जी, हाँ अभी कर दीजिए। डॉक्टर पटनी एड्रेस कर लेंगे, देन वी विल स्टार्ट।
हाँ, यस यस।
हो गया, बस ऐसे ही दोबारा शेयर भी इसी तरह से।
हाँ हाँ, यस यस आई।
जी
एक्चुअली वी आर वेरी अकस्टम्ड ऑन जूम।
हाँ सर, पर वो मोर और लेस
हाँ,
सारे बटन
एक ही
सिमिलर हैं,
जैसा
बस थोड़ा सा किसी ने साइड पे कर
हाँ।
दिया, किसी ने ऊंचा कर दिया।
वो एक ही है सब।
कोविड ने ये अच्छा सिखा दिया हम सबको।
हाँ, सब सिखा दिया। मैडम, कोविड की वजह से मेरी एक्सरे की बुक आ गई। कोविड की वजह से अभी मैंने इनकाउंटर विद माय टीचर ये बना रहा हूँ। कोविड की ही है सब है।
हाँ जी हाँ जी।
एंड आई हैव बिकम वेरी पॉपुलर ऑन यूट्यूब बिकॉज ऑफ कोविड। क्योंकि कोविड में हम लोगों ने सारे क्लासेस, सारे एग्जाम सब उस पे लिए।
बिल्कुल बिल्कुल, वो ब्लेसिंग इन
सब सिखा
डिस्गाइज
दिया।
था।
हाँ,
पीपल,
ब्लेसिंग इन डिस्गाइज था।
even I also utilize that time for doing constructive work which we are otherwise not able to do.
नॉट
uh,
एबल टू डू दैट।
हाँ जी। Dr. Rajiv Patni has joined us.
Good morning, namaste, and a happy new year to everyone. So
Same to
nice
you. Thank
to
you.
see you, Dr. Sangeeta, and welcome to the webinar, Dr. Rajendra Prasadji.
Thank you, sir.
Wonderful to have you with us. I see that you're an honorary consultant to AFMS, also Armed Forces Medical Services.
Yes, I have been, yes.
Yes, yeah. So my background is from AFMC and Air Force. So
Okay, okay.
nice to see a kindred soul here.
Anil Chand Anand, you might be knowing, he was my class fellow
अच्छा अच्छा
from
एक
KGMC.
gastroenterologist.
AC Anand, yes.
हाँ हाँ
AC Anand, RP Chaube, many of my class fellows have been in there with you.
वंडरफुल वंडरफुल तो आजकल आप लखनऊ में हैं
I was in Patel Chess as a director. Basically, I belong to KGMC.
केजीएमसी ओके
I lived in KGMC for more than 40 years. And then I became director of SAFI first, and then Patel Chess Institute.
Wonderful.
And
So
I
we are honored
superannuated in 2000.
to have you with us today, sir. Uh, so much experience and such an esteemed personality has joined us. For the
सर
benefit.
एक और बात शेयर करूं सर को अभी रिसेंटली दिस ईयर ही हैज बीन अवॉर्डेड पद्म श्री अवार्ड.
Oh, awesome. Congratulations, sir. Wonderful.
Thanks.
And wish you
Thanks.
many, many more. I'm sure this is duly deserved recognition. That's great news, sir. Very nice. So, um, all the participants here on behalf of National Health Systems Resource Center and the Quality and Patient Safety Division, and the expert, Dr. Sangeeta Sharma, is with us here. We welcome everyone to this new series of webinars. We have been running the STG webinars for the last 3 years together with Dr. Sangeeta Sharma here. And now this is the fourth iteration of the same. 36 odd sessions we've had, and two sessions in each webinar. So that's a repository.
Minimum two.
Light,
Sometimes three.
light. Hello.
So that's, yeah, 70, 72, 75 or so experts have spoken on this webinar session. For those who have joined us for the first time, let me just refresh our knowledge and welcome you on board. We have a very strong attendance and a very popular following of this webinar series, the Standard Treatment Guideline series. The idea being that we have healthcare services and everyone is doing their bit, but we need to make it effective, safe, people-centered, and the way quality care is being provided. It's in silos, there's lack of integration and variability in standards. So standard treatment guidelines, they come into play, and they assure the quality of care is provided to everyone in the same manner, the same access, the same treatment, and safe and rational treatment is provided. In this journey, over 12,000 professionals have joined us. And once again, for those who are new, everyone who finishes the pre-test and post-test successfully will be awarded a certificate. We are in talks with the Delhi Medical Council and National Medical Council to give CME points for those. Till date, more than 4,250 certificates have been awarded to the participants. With this, I will pause here and let the experts take over. In today's session, the experts, we are honored to have Padma Shri Dr. Rajendra Prasad ji with us, and Dr. Raghuram Rao, who is from the TB Central TB Division, Ministry of Health, will be joining us shortly. Both are renowned experts in their fields, and it's my honor to welcome you to this webinar series. I'll pause here, and Dr. Sangeeta Sharma, Madam, would you like to say something?
Thank you, Dr. Patni, for continuing this series. And we are very happy that this is the fourth year and consecutive year. It is commendable on part of the NHS RC and the participants for showing their continued interest in this. I thought people would be bored by this time and we need not continue. But then I learned that there is still, demand for this. So we were very happy to collaborate and continue this series. As usual, we try to find out the national level experts who have a real ground level experience, who have worked at different levels of healthcare, and who are well versed with the ground level situations, particularly in the peripheries and at the peripheral level. And you know As usual, we have the mix of participants here: doctors, nurses, chos, quality officers. They like to join us. One word for the format. Dr. Patni has already said that, but just to reiterate, I had said this earlier also, that we have pre and post test for the series for all the sessions. So pre-test link is there in the chat box. Please do attempt that. Just don't think about the numbers or the score that you get. Take this as an educative exercise. This would be anonymous, except for certificate pers- for certification purposes. We are asking for the name and the mobile number, but rest, be assured that we are not looking at the scores. All we are trying to do is to cover different case scenarios that we come across in our clinical practice, and there is an explanation given for each question. So maybe later you can read that in detail, but I'm sure that you will find the right answers during this session itself. If anything is remaining, you can read those explanations later, and take this as an educational activity only. I'm also happy to share that we had been able to publish the results of the first series in a journal. I can put the link here. This is an open access journal. Maybe you would like to go through that. There were certain really very important insights coming from these tests, and this also let us know the areas where people need strengthening, and which should be covered in these webinars. I think with this, I would like to welcome Dr. Rajendra Prasad for inaugurating the fourth, series today. And Dr. Ranjit, you can introduce him, and then we can start the session. There is some sound is breaking. Ranjit?
Sound is breaking, yes.
Ranjit, audio at your end is not... maybe you've joined from two devices. You can move to another device. नहीं आ रही है आवाज रंजीत आपकी.
Ranjit, maybe you can join from your mobile phone in case this is not working. Okay? At least welcome, and then the speakers can take over. Do we have some...
यहाँ से
Hello.
नहीं आपके एंड पे प्रॉब्लम है. आई थिंक वी हैव इन अ वे इंट्रोड्यूस्ड हिम, Dr. Rajendra Prasad. He is a renowned pulmonologist. He was at KGMC for 40 years, and then he was director Patel Chest Institute. Then he joined as director Safai. Okay, yes, I think he has a long CV. Now currently he's working at a as a director medical education, and professor and head of Department of Pulmonary Medicine at IRA University, Lucknow. And as would know, that he had been member of various international organization associations working on TB, and national organizations. Earlier, he had been honorary consultant to AFMS in respiratory diseases, and he was the first. He had a pivotal role towards establishing one of the first dot center in KGMC, and he has a distinction of being president of all major scientific bodies in the field of pulmonary medicine in India. National Chest College of Chest Physicians, Indian Chest Society, Indian College of Allergy, Asthma, and Applied Immunology, Indian Association of Bronchology, Tuberculosis Association of India. And he is very academically very active, and has more than 215 researches, and has published 600 original articles. That's commendable, sir. With very good citation index and H index of 57, and which is outstanding index from all yardsticks. And he is also has earned that accolade of being known as father of pulmonary medicines in Uttar Pradesh, and recipient of more than 80 awards, lifetime achievement award of National College of Chest Physicians, Indian Chest, from all these societies, and has delivered many orations. And I think the latest accolade in his feather in his cap is this Padam Shri Award. This is one of the highest category award of the country. With you, we welcome you, Dr. Rajendra Prasad. May please take over the session.
Thank you, Dr. Sangeeta Sharma and Dr. Ranjit and other officials. And I'm very also thankful to NHSRC India for inviting me for the first session of this series. So you made me a Sunil Gavaskar of the team in that way. And because I took name of Sunil Gavaskar, there have been many opening, but in our time, Sunil Gavaskar was the opener. So let me share my slides, and may I know, Dr. Sangeeta, how much time I have been allotted? About half an hour or less than that?
45 minutes, sir.
45 minutes. So I'll not to hurry. So, and
Sir, ये
actually,
बहुत important topic है TB वाला, and I think there are lots of things that need to be covered. So please take your time. We have 45 minutes with us.
Raghu Raman will join at what time? Some approximate time? Because
Ranjit,
we have been colleague, we are still colleague in NTEP.
सर आप अपना सेशन स्टार्ट कर लीजिए.
Okay. So actually, if you see my topic, it is very general, that National Tuberculosis Elimination Program. Although its name has further changed, I'll let you know during my speech, during my talk. And just हम 5 बजे आएंगे. हाँ ठीक है, पूछ लेना. So whenever I start any lecture, I used to show few slides. I'm showing you that if you want to shine like a sun, first you have to first you have to burn like sun. This was said by none less, anybody less than APJ Abdul Kalam, our former president. And I usually have another, I don't know how it will move. It is coming in my slides way.
सर ये कर्सर है, आप डजंट मैटर इसको।
नहीं, ये जो हमारी जो फोटो आ रही है वो स्लाइड्स के ऊपर आ रही है। हाउ
हाँ,
कैन
वो
आई
सर वो
गेट
तो
इट डाउन?
गैलरी की है ना, गैलरी में है।
हाँ,
आपकी हमें स्लाइड पूरा दिख रहा है।
दिख रहा, ठीक है।
हाँ सर, ठीक है, बिल्कुल।
So I usually say better than 1,000 days of diligent study is one day with great teacher. I don't say that I'm a great teacher, but I said these words to slides are not moving. I don't know.
सर वो नीचे वो एरो होगा ना मूव करने के लिए।
नहीं है, वही कोशिश से कर रहे हैं लेकिन हो नहीं रहा कुछ।
रंजीत, कैन यू टेक द कंट्रोल?
Should I unshare and share it again?
हाँ सर, वो एरो आता है नेक्स्ट स्लाइड का, वो उससे
वो
नहीं
तो
हो रहा है।
है, सब पता है। नहीं हो रहा, दोनों से।
सर स्टॉप करके फिर से शेयर करना होगा।
हाँ, मुझे लग रहा है ये।
यस सर, विजिबल है सर।
नहीं,
Okay.
मूव करके देख लो
Yes,
स्लाइड।
yes.
हाँ, अभी चल रहा है
So,
सर।
yes, yes. Challa.
हाँ,
So I said these words that the better than 1,000 days of diligent study is one day with a great teacher. I'm not saying I'm a great teacher, but I said these words for my mentors, like Professor Khanna and so many. Even from Delhi, P.N. Tandon, Hari Gautam Saab, they have all been then Dr. Ganguly, all have been my mentors, apart from KGMC. And I'm happy to inform that if somebody can follow me on YouTube, my YouTube is just Rajen Prasad at KGMC. So you'll find these video podcast. What I did, I'm doing it on for last 2 years. I chosen about 20 teachers and how I learned from them, what lessons they taught me, and whatever I am today because of them. So I'm just tributing these encounter with my teachers. There are about 100 episodes. Already 7, 8 episodes have been in air. So I would request if somebody is interested to know about these great people in the face of earth. Many of them are not now, not live today, but I have interacted with them. So you can follow me on my YouTube. It is just Rajen Prasad KGMC. You just write on YouTube, you'll go to my. So I would start, the in month of May, our Prime Minister Narendra Modi chaired a meeting on India's mission to eliminate TB. So in this program is a very high priority, what I wanted to say. Driven by the active public health participation, movement has gained significant momentum over the last few years. Our government remains committed to working closely with the stakeholders to realize the vision of a TB-free India. That's a real vision. And you can see Modi ji himself, apart from Mr. Nadda and so many, they have attended this meeting. And they have reviewed and they have shown satisfaction the way the program is running. And PM also reviews the recently concluded 100-day TB Mukt Bharat Abhiyan, because its name has been now changed as a TB Mukt Bharat Abhiyan. It will come in the few next slides. And then, and he has shown satisfaction. And PM said that since TB is now curable with regular treatment, there should be less fear and more awareness among the public. And it requires a regular. PM herself advocated that it requires regular treatment. Highlighted the importance of cleanliness through Jan Bhagidari. So all those things he addressed in this review meeting. And he also said that Global TB Report 2024, at that time 22, now we have 25 report also, which confirmed an 18% reduction in the TB incidence in India, because many people talk very loosely that TB is not, but so there is a 18% reduction in that WHO report 2024 from 237 per lakh to now it has come to 187. At that time it was 195. And from 2000, between 2015 and 2020, 2015 is taken as a base, and the 85% treatment coverage, and with good amount of control. He also reviewed the infrastructure enhancement, including expansion of the TB diagnostic network, like NAT. You know that 87 culture drug susceptibility lab, over 26,000 X-ray units, including 500 AI enabled. Now you know everything is AI coming up, handled X-ray devices, with another 1,000 in pipeline. The decentralization of all TB services, including the free screening, diagnosis, treatment, and nutrition. Nutrition has also come up as a very important segment of TB elimination, TB Mukt Bharat Abhiyan. And so this what he reviewed and what is. I am in this, I'm a pulmonologist, exactly you say from last 50 years today. I joined Department of Pulmonary Medicine as a junior resident in 1976. So already 50 years have completed. So we are working with this chest disease, and TB is major component of the chest disease in India. I usually say half of the chest disease is TB. So, and when I say about tuberculosis, I always say that almost it is a curable disease, provided treatment are prescribed correctly, and it should be taken also. Now, only prescription will not cure. So if both the things are happening, I myself had treated lakhs and lakhs of patients in last 50 years. And I say it is almost curable disease. But very unfortunate, Global Report, TB Report 2025 says that in India, about 3 lakh patients died in 2024 with tuberculosis. It's really a paradox. Although this death has been reduced, it was very high few years back, but still a lot of people are dying. And this is the Global TB Report 2025 that about in India we have around 28 lakhs of TB patients. Mortality is also around, I said in India, globally it is about 1 million. And then MDR and XDR, drug resistant TB also in India about 130K, about 33%. So India has a high global burden. It is among the high global, high TB burden countries. That what I wanted to communicate. And even drug resistance, our own National Drug Resistance Survey conducted between 2014 and 16 says, yes, there are presence of a drug resistance like mono drug resistance, MDR-TB, pre-XDR-TB, and even XDR-TB. They are present in the country. And then usually I ask a question, why this is happening? A disease which is a curable, almost curable. Why this is happening? And answer is simply that every patient, ideally we have a good program, everything, but every patient is not reaching to that program. It means every patient is not effectively being treated. If every patient are diagnosed early and treated with very potent and effective regimen, there is no question of death. And poor management, when I say I can share you, I can talk you hours and hours, still the teaching is poor, what I am saying. This is somebody, I am quoting you one of the prescription who is a 63 kg weight, 63, mind it, and he wrote rifampicin 450. This is inadequate dose. So like this, I can show you many prescriptions which are inadequate even today. And I personally believe, no doctor wanted to treat any patient wrongly. But it is the education which is very important. And so I would like to say here very clearly that education in TB especially is not as good as it should have been. Otherwise, why person should write a wrong dosing? So that needs a very clear emphasis. I usually talk in the government and say that we need more and more education. And how this program has evolved. I wanted to let you know. Before 60s, we have no drug, hardly any drug. So in 62, you see, the government has launched National TB program through District TB Center. And when it ran for about 30 years, it has not, and it was evaluated, and they said it has not done, it is not able to control tuberculosis. So government has revised the program in 1997. And before that, in 93, WHO declared TB as a global emergency. So 97 program name was changed and it was known as Revised National TB Control Program. And then in 2000, second phase of RNTCP started pan-India 2005 to 11. And 12 to 17 National Strategic Plan was there, mandatory. Notification was made mandatory. And rapid molecular tests were introduced in this period. Active case finding were also introduced in this mission. And then from 2017 to 25, there has been NSP, and it is a patient-centric care for TB elimination. And in 2020, National TB Elimination, it was renamed as National TB Elimination Program. And in 24, it was renamed as, now it is known as TB Mukt Bharat Abhiyan. So we are working on a TB Mukt Bharat Abhiyan. This was, I'll skip some of the slide, quickly move that this was the district tuberculosis program, how the TB control program ran in country. This was evaluated in 92 and they say that it has not worked properly. And WHO declared emergency 93. RNTCP came, RNTCP came in a better way where political commitment, diagnosis by microscopy was there, adequate supply of the dry drugs were there, directly observed treatment was introduced, and accountability. Every record is being kept. So that was the components of RNTCP with the some targets that from 1990 to 2015, half the prevalence and death. That was the target. So and when program ran, this RNT this program ran from this, then they found that it has practically achieved its targets. Reduction about 50% in incidence and mortality. And but still, lot of people are dying. Lot of tuberculosis is there. So government has changed its name as TB, and now we were working on a TB elimination program, and finally it has also changed in 2024. What is NTP? I wanted just to share with you. NTP is a that it is a global milestone to end the TB strategy. Usually it is through the Sustainable Development Goals, and vision is word-free TB, where it should be zero deaths, zero disease, and zero sufferings from tuberculosis. And this is actually the end TB, a TB elimination. But we are working towards that. And and the milestone and target has been fixed, and target was fixed by 2023 by Sustainable Development Goal and by NTB strategy 2030. And they say that we should be able to reduce the TB deaths by 90% by 2030, and reduction in TB incidence by 80% by 2030. And there should be no catastrophic expenditure due to TB. It should be zero. So that was what is the targets have been fixed. And India, luckily, our Prime Minister is very, very interested in this program. And he did Delhi NTB Summit in 2018, where we were part of this summit, and he declared that Government of India wants to end TB 5 years before than the SDG time, that is by 2025. We were the part, I and Dr. Bera and Dr. Arora attended that meeting. And now Indian target, we see, in 2000, as I said, it started from 2015. Incidence was 237 per lakh. Slowly it is coming down. And but the our target was by 2025 it should come at 47 per lakh. But we have been able to reach, we have further came down, it is 187 per lakh as per last report. So still we are far from the target, but we are trying to work through that. And same is to the mortality. Mortality was in 2015 around 28 per lakh, and it is coming down slowly and slowly. But our target is by 20, it was 2.8, but we have reached up to around 21 per lakh. So still we have to do lot of work to eliminate TB from India. And to eliminate TB from India, we have made this national strategic plan, I said in 1725, in which we have seen 4 components. First is to detect all TB cases. Then is to treat all TB cases. And then you prevent, even that, the prevention was also one of the arm, and to build the infrastructure. This is the 4 essential components of National Strategic Plan 1725. And in 2530 they have further, since 25 is over, so they have made another 2530 for TB elimination. This meeting was held and government is working on it. And as a clinician, many of you are treating tuberculosis, and in those thematic areas, further incidence reduction, mortality reduction, out-of-pocket expenditure, strengthening the health system, strengthening multi-sector involvement, strengthening surveillance, research. So all those things have been kept as a thematic areas. Now, there is a little change in the definitions, although very little, but the little change. Now we have got case definition, only two types of, initially we used to talk sputum positive, negative, but now with the molecular diagnostics, we say that microbiologically confirmed tuberculosis, may it be pulmonary, may it be extrapulmonary. When I say microbiologically confirmed, it means that either the phenotypic, that is AFB is positive, or by genotypic, that is the true nat or gene expert is positive by molecular things. Anything, any specimen is positive, then that patient will known as microbiologically confirmed. When I say suppose I usually take example of lymph node TB. Suppose you have a lymph node, you did FNAC, you took some sample from that. If FNAC only shows cytology suggestive of TB, it will be a clinically diagnosed. But if that sample what you took, it also shows AFB or gene expert or true net positive MTB, then it becomes a microbiological. So same disease, so microbiologically confirmed means it is positive either by genotypic or by phenotypic bacterial methods. The rest of the cases will be known as clinically diagnosed. And there was hardly any other change, only in our time we used to talk relapse, and that relapse word has been changed as a recurrent TB. That's only change has occurred. We have large amount of diagnostic expansion to achieve this. As I said, the first arm was to detect. To detect, we have, apart from X-ray and microscopy, we have a lot of molecular diagnostics like TrueNat, like Gene Expert, culture, LPA first line, LPA second line, all those things are available in the country. And we have a huge number of these labs as shown in this slide. National reference laboratory around 6, 7, intermediate reference laboratory about 37, culture and DST laboratory about 63, and NAT machines are around, now it is crossing about 10,000, and peripheral level microscopy is over 26,000. So we have lot of labs. So with this all event, we have revised the diagnostic algorithm. And in diagnostic algorithm, apart from the X-ray and smear, we have also introduced the molecular diagnostic. So molecular diagnostic is today the choice. And even for drug-resistant TB, we have a very clear-cut algorithm where whole program is working on that particular, in which the first line LPA, second line LPA, gene expert, culture, sensitivity, all and X-ray, all those things are employed. And initially we were working on a passive case finding, means anybody who is reporting. Now we have moved towards the active case finding and intensified case finding, especially in those vulnerable population. We are actively screening about the tuberculosis. And then a lot of measures have been taken to improve case finding. Initially, we have only 4 symptom screening. Now we have 10 symptom screening. Cough, more than 2 weeks, fever, night sweat, weight loss. These were the 4 initially. Then hemoptysis, shortness of breath, chest pain, loss of appetite, tiredness, nodular swelling neck, as I just referred to, or any extrapulmonary symptom. They're all taken as now presumptive TB. Initially, we used to talk TB suspect. Now it is known as presumptive TB, and there's a 10th symptom of presumptive TB. And even asymptomatic, many patients of TB are asymptomatic in vulnerable population, especially like HIV, diabetes, past history of alcoholic, smoker, coal miner, silica worker. So all those asymptomatic TB screening. Now we are doing a lot of cases we are getting. And case notification is increasing slowly and slowly. And initially we had around in 2015, we have missing cases significantly was about 1.5 lakh, and now it has significantly reduced around 1 lakh. Still 1 lakh patients are not being traced and not being diagnosed, but majority of them, if we have 28, about 26, 27 lakh people are being diagnosed and put on treatment. That's very good news. TB incidence and mortality, as I said, it was 2015, it was about 237, and by 24, it has come up to 187. We have slowly and slowly declining incidence. And same way, mortality also, it was 43, it was around, say, India mortality was around 28 in 2015, and it has come to 21 per lakh. So it is also reduced further. And this reduction is far ahead than the global reduction. Even drug-resistant TB, lot of drug-resistant TB are diagnosed. Last year, there are more than 65,000. And when you talk about tuberculosis, there are 2-3 points I would like to emphasize, that all patients initiating treatment for pulmonary TB, these are the clinical standards, should be provided counseling and education. Anybody who is treating tuberculosis, it is his duty now to counsel your patient, to educate your patient so that he completes the treatment. And then another thing has come, public health action must be conducted, and notification. Anybody who is treating tuberculosis must notify. This is now a punishable offense if you are not notifying. Although government is not doing on that, but yes, there are provisions. And then another public health action is that if you are a TB in treating a TB case, you must do a contact investigation. Go to the call family members or go to the family members to see for any evidence of tuberculosis. This is known as contact investigation, so that you can provide a preventive treatment. And the long-term follow-up is also have been, if you are treating tuberculosis, today rule says, when you stop the treatment, you follow it for next 2 years. If any tuberculosis recurs, then you should be able to detect and treat it. These are the public health risks. Anybody who is treating tuberculosis, he must do all those things. And as far as TB treatment is concerned, now we have got 2 types of treatment, drug-susceptible TB and treatment of drug-resistant TB. In drug-susceptible, still standard says that 4 drug therapy for 2 months and 3 drug therapy. In India, we have included ethambutol also in a continuation phase. So 4 drug means rifampicin, INH, ethambutol, and pyrazinamide, followed by 4 months of INH, rifampicin, and ethambutol. And then this is usually a fixed dose combination. And this is a weight bands by which you can provide the drug doses. Drug-resistant TB also, we have already said, we have a lot of drug-resistant TB in India. And diagnostic algorithm and treatment, everything has been fixed. I'll say it after some time, especially when we are talking about drug-resistant tuberculosis. And to treat drug-resistant TB, now we have in India, first choice goes to somebody who is more than 14 years. First treatment should be 6 to 9 months of B-PAL-M shorter oral, all oral. Now, another news is now we have all oral regimen. So first, this is introduced last year in India, B-PAL-M. B stands for bedaquiline, PA stands for predominant, L stands for linezolid, and M stands for moxie. This is B, Pal, M, shorter, oral regimen. It is for only 6 to 9 months, whether you have MDR, pre-XDR, or XDR TB, this should be the choice. And if you cannot provide this regimen, then you can go up to 9 to 11 months of shorter oral MDR RR regimen. That is another which was introduced in country long back. And if you cannot provide this, if there is a contraindication, and then we have to go for longer all oral treatment regimen for MDR and XDR TB. And then about 6 to 9 months of, if you have monoresistance or polyresistance other than MDR TB. When I say monoresistant, resistance to INH. When I say poly, INH is streptomycin, because these drugs were used for long back. And then 6 to 9 months of HN monopoly, the treatment is provided. We have index TB guideline for treat extrapulmonary TB. It is essentially the same that in some of the extrapulmonary, you have to use steroids like TB meningitis and TB pericarditis. Even with all those innovations, the treatment success rate has also been very high. For drug-sensitive TB, we have reached around 90% of the success. And even for drug-resistant TB, which was initially 40 to 50%, now it has increased with newer regimens, about, say, 50 to 70%. So that's a good news has happened with all those regimens. And there's a lot of new initiatives have been taken. Use of bedaquiline, initially it was not used less than 5. So now if anybody is more than 5 years and 15 kg, we can use. Use of delamanid in every age group is allowed. Bedaquiline during pregnancy is also allowed. And shorter preventive treatment, tuberculosis, PTP, tuberculosis preventive treatment regimen. With the advent of rifampicin and isoniazid, 1 month course of shorter regimen has been introduced. TB preventive treatment B-PAL regimen, Avlitag have been introduced. Shorter oral regimen with linezolid. So many new things. Whatever world is doing research, we are all adopting that. And there is a lot of lot of diet, lot of portion. We have Nikshay Poshan Yojana. In this recently it was revised about 1,000 per month for every TB patient, and for drug sensitive or drug resistant, and even for preventive treatment there is some incentive. And in somebody who is reporting, from them even incentive. Also on the hill and difficult areas, they have incentive. So government is provided a lot of incentive and even giving incentive to ASA workers and community volunteers. And the TB preventive treatment has been expanded. Initially, it was done only in HIV and TB, but now has been expanded. And intensified TB case finding, I have already talked that in vulnerable population, even without symptom, you have to screen for TB. And the government has introduced Nikshay Mitra initiative. More than 2.25 lakh people witness. Launched this, Honorary President has launched this program. Additional diagnostic, treatment, nutritional, vocational support. They provide support to the patient, encouraging committee to become a Nikshay Mitra. So this program is running in India. And medical college, this is a program where medical colleges has also been involved. As you see, there is a task force mechanism. We had task force at national level. And I have been, still I am a vice chair of National Task Force. And then we have got at zonal level, countries divided into zones. And then at state level has STU and STF chairpersons. And then we have a state task force. And then we have core committees at each and every medical college. So all the medical colleges, more than 600, have been involved in this program. And medical college role are very, very well defined. This is engagement with NTP is a first role. Training and teaching is a partial part of the part and parcel of medical colleges. Advocacy, you should be advocates, and so all those things medical colleges have been involved. I have shared this slide you already that if global reduction of TB was about 9%, but India it is happening at this pace of 18%. And TB mortality is also reducing, and catastrophic cost is still there in India. So adult BCG vaccine has been there in a research mode, you can say programmatic research mode. Still, I think they will analyze and they will further. 100 days TB campaign has been there in India. Mr. Modi has already referred 100 days campaign. He was very satisfied. And goals of this campaign was to increase the case detection, so intensified activities, IEC Act campaign, reduce the death among people with TB by implementing differentiated TB care, approved with approach with nutritional support intervention, the prevent occurrence of new TB cases in the community by providing TB preventive treatment. So all those things in India is being to prevent occur new TB cases, preventive treatment to household contacts, PLHIV, and vulnerable population. All those things have been there. And the TB Mukt Bharat, as I said, was aimed to reduce the incidence and reduce the TB mortality further. And TB Mukt Bharat Abhiyan country has made a lot of progress. As you see that about 18.6 crore estimated 28 crore vulnerable populations have been identified and assessed. And handheld X-rays, I have already talked, diagnostic network utilization, and meeting with the state health. So a lot of things are happening to this TB Mukt Bharat Abhiyan program. And we have partnered with many ministry because only health ministry cannot eliminate TB. So we have to partner with other ministries like Ministry of Youth, Railway, Defense, Labor, and so on. So, and we have TB-free workplaces. We are TB-free state, TB-free. We are working on TB-free, TB Mukt Panchayat initiative and institutional. But still, what I'm trying to say, we have progressed a lot. We are going on a very high speed, but still there are challenges. Time ahead, we have and at the reaching the unreached, many places we have not been able. Huge reservoir of latent infection, so preventive TB has to be massively covered. Social determinants outside the health. That's why a lot of ministries have been involved, which is not only the health. Quality of care in the private sector is another. A lot of private sector being involved, a lot of initiatives are being taken, but still we have to do a lot more. Stigma is another issue. Still, I believe that stigma is still there with TB. Although we have stigma in those days where TB has no treatment. But now we have full treatment. There should be no stigma, but still, so we have to work a lot. I think here I'd like to say TB Association has started a campaign to remove stigma and discrimination. And especially drug resistant initially was poor, now it is slowly and slowly. So these are the challenges we are faced. And with this, now I always say it's a time to come together. We have to work. I'll repeat here. It is not only the government. It is not only the doctors, everyone in the community. That's why Jan Bhagidari, our Prime Minister, has declared. Community reach should be there. So it's a time to come together. Everyone has to come together. I say another word, have to work in a mission mode to end TB from India, which is dream of all of us. Why India should have TB? Why so much people should die? Although we have come forward, but still we have to work in a mission mode to see that India should achieve NTB targets. With this, probably I have come to end of my presentation. And for you, as I said, I have my YouTube channel. I've already talked to you, Rajendra Prasad, KGMC. And we have many lectures on YouTube, like recent changes, masterclass on tuberculosis, test X-ray interpretation. We have books on tuberculosis, especially adverse drug reaction. I have a book. We have book on chest X-ray. It is available everywhere. And so you can, some of you are interested, you can go on to my YouTube and you can see these lectures and benefit your patient. With these few words, I would like to end. And again, in the end, I'll say that anyone, this is my I learned it very long back, anyone who keeps learning stays young. Learning, there are two advantages. One, that you will be able to serve your patient. That is advantage number one. Advantage number two, it will keep you young and healthy. So with these words, I once again thank you, all of you, for giving me opportunity. And if you have any question, I love to answer those questions. So thank you very much.
Thank you, Dr. Rajendra Prasad, for motivating the group. And today I'm very happy to see there is a huge participation. We have around 500 people attending this session today, and your words are motivating. And you've rightly emphasized, though we have made a lot of programmatic progress, but still the burden is high. We cannot afford to be complacent of it, and we need to, make it consistent so that this TB does not resurge or the statistics don't return. So it is very important. And as I think during his session, he already pointed out that there are a lot of diagnostic challenges that we have. Typical patients are there, but many a times atypical presentations are there, where the diagnostics become very important. But even in the typical cases, if these diagnostic tests are not applied consistently or in a scientific manner, again, it can lead to problems in the management, because some of them either get over diagnosed as TB, or mostly it is the underdiagnosis of TB that becomes the problematic. A lot of progress scientifically has been made with this CB0, these molecular tests which are now available. A lot of it, the diagnostic time required for getting confirmation has been reduced. So, but we do see that these are either problems with the access to these tests or utilization of these tests, and many times the interpretation of these tests is problematic. I think if these things improve, the management part will also improve. Even today, I don't know, Dr. Rajendra Prasad, are there any studies of the kind of regimens used today, by public sector doctors and the private sector? We did this study quite a while ago, years ago, and we found that everybody was using different regimen. And even this was happening because even with the having a national program guidelines in place, but people were still using different regimens. In your experience, what do you find? It has improved, or is it the people are still, experimenting with the regimens?
Well, you have raised something very important. And I used to tell, I have slides, but I just skipped that. Initially, the study was done in around 2000, that lot of regimens are being used, and lot of regimens are inappropriate. Then further, I did my own study in 2005, and we found that number has been reduced, but still lot of inappropriate. But still, I believe inappropriate regimens, though it has reduced, because government took over this program very effectively. So many of the people are going to the government. When it goes to the government, they cannot default because there are fixed regimen, fixed dosing, everything. And but I have shown you in my initial presentation 4 or 5 prescriptions. I did it little hurriedly, but they're all wrong. And my perception is it is because of the deficiency in the medical curriculum teaching. What I have learned from last 50 years. Nobody tuberculosis. Now you see the recently the tuberculosis and chest department or respiratory department have been rather abolished in those medical colleges who have only the undergraduate training. But I believe at the undergraduate level, the training must is very component and very, very essential. Those are the formative years. If you have not learned in those years, you will not able to learn in future. So I agree with you, Dr. Sangeeta, that although it has reduced, but still there are wrong prescriptions. Patient side also, they live in between. Otherwise, why 3 lakh people should have died? If everybody is prescribed correctly and everybody took the treatment, then nobody should die, as I understand, as I have experienced. So you raise a very important question that education, to my understanding, being a teacher, being an educator in last 50 years, I am a very firm advocate of there should be a very enough standard of education, especially for respiratory diseases, and among the respiratory diseases, especially for tuberculosis. Although government is doing a lot to educate people, but still it requires further action. Thank
Yes.
you, Dr. Sangeeta.
Yeah. In this times when we have these national guidelines, regimen has been proven, we must adhere. So one take home message from today is that whatever, we don't have to experiment. There are, this is the domain of researchers, academicians, sitting at the quaternary care. They can experiment different things, but for us at the ground level, I think the best approach should be that we follow the regimen in letter and spirit. There are 1 or 2 questions, sir, if you would like to take that. There is one
Yes.
question about how to improve loss to follow up. Any strategy, anything from your experience that you find that will be helpful in improving this?
I think that is a very important question. In all the programs, everywhere, in private clinics, last to follow up is there, 10 to 15%. And I say now the every guideline has made it mandatory that there should be enough health education, not once, at every subsequent consultation. Whenever patients you get a chance, you educate your patient that you have TB, don't fear about this disease today, and whatever treatment has been prescribed, you have to consume it regularly for desired length of time. And I personally feel, as you know, these loss to follow up occur differently at different clinics with different doctors, different hospitals. So probably if you educate every patient enough, nobody would like to die. Nobody wants to die, madam. What I say always, nobody would like to die today, but it's still happening. So I think education, initial education, and at every consultation time, at whenever you get an opportunity. Although government has introduced lot of these programs, but still it needs an improvement that somebody loves to follow.
So there is one more question. Dr. Raghuram Rao has joined, but there is
Yeah,
one
I saw
question.
him. I saw him. Yes.
Does hemoptysis or presence of blood hamper accuracy or give false negative test on CB naught?
No, it is not known. But hemoptysis, I always say, I love teach hemoptysis. I will request Sangeeta sometime in you just because there's a lot of misconception about the diagnosis, treatment of hemoptysis. But if I say one line, I have taught my MBBS and PG students for now more than 40 years. And I said, if person who gets hemoptysis is a lucky patient of tuberculosis. There are two, three meaning to it. Once he is diagnosed early, suppose you have a cough, you may delay. But once you have a blood in your sputum, blood from anywhere, you don't delay, you consult. And usually you consult a good doctor. ऐसे तो आप कहीं चले जाओगे, but if you have a hemoptysis, and usually that is motivation for patients to consume the treatment fully. So I always say, if you have hemoptysis in beginning, in tuberculosis, you are a lucky patient, and usually those patients, and this I have experienced in my last 45-year career.
Sir,
Otherwise,
this
it
is
doesn't happen
true.
diagnosis.
I fully agree with you. This is very scary for the patient. Like,
Yes,
blood in stool is also very scary.
yes,
I always
everywhere,
tell,
anywhere blood.
I always say, you don't have to treat all watery diarrhea cases with antibiotics. If there is a bacterial infection, if there is bacillary dysentery, it would be so scary for the patient himself that you will not miss it.
Thank you, Sangeeta ji. I think
Sir,
Raghu Raman
welcome.
has
Thank you.
joined. Good evening, Dr. Raghu Raman.
Good evening, sir. Good evening. Namaskar, sir.
नमस्कार,
Evening
बहुत
to
दिनों बाद
everybody.
आमने सामने मुलाकात हो रही है.
I couldn't attend the ZTFs and the NTS.
Yes,
But
yes.
yeah. It's nice, sir. Great to see you, sir. Listen to the lecture also. Wonderful, sir. And I think
Thank you.
I'll take forward from there in the next session.
Yes.
Good, interesting. Yeah.
Thank you, Dr. Sangeeta.
Thank you very much, sir. Thank you.
Thank you so much, sir. Moving forward, I would like to invite our second guest speaker, Dr. Raghuram Rao, sir. He is working with the Central TB Division, Ministry of Health and Family Welfare, and with around 23 years of work experience in public health on clinical management, capacity building, health system strengthening, and environmental health. He has worked extensively with NACP and NTEP. He has led several portfolios under NTEP, which involves various pioneering efforts for TB-free India, such as subnational TB-free certification, surveillance and M&E, ICT applications like Nikshay, AI and digital interventions, DBT, policy and planning, integration of NTEP services within NHM, donor coordination and engagement of various stakeholders, including civil society and corporates. In addition to this, he also shoulders multiple responsibilities related to planning and implementation of NTEP. During his stint with National AIDS Control Program, he contributed towards development of national and operational guidelines for ICTs, country level planning for the program, scale up of ICTCs and PPTCT in the public as well as private sector, and liaising and coordination with technical resource groups, development partners, and other stakeholders. Over to you, sir.
Thanks a lot to the entire team of NHSRC, and thank you all for the participants also. It's a very nice opportunity to share our thoughts in terms of the technical knowledge from one of the senior most professors in the country on tuberculosis, and I'll speak a little bit on the on the from the angle of primary care, of what does these guidelines, what does this policies mean when you're working at the primary care level. So would you be sharing the presentation you want me to share?
Yes, sir. We'll be sharing a presentation
Please
from
do
here
that.
itself.
Please do that. Yeah, yeah. So, well, I do that. So tuberculosis, since some of the topics as of the structure, the interventions has already been covered by Dr. Prasad. I'll be just touching about it, but not going into the details of that, so that it's not repetitive. We'll save some time and we can have more discussions on that. Right. So tuberculosis, like Dr. Sangeeta also said, this can occur across any part of the body except the dead parts, which is our hair, which is our teeth, and which is our nails, the dead tissues. Except that, please go to the next slide, except that TB can occur across any part of it. So you'll have largely hemoptysis, cough, weight loss as the primary symptoms, fever, evening rise of temperature. But there are many extrapulmonary specific symptoms that could be there depending on the site, whether it's lymph node or the TB of the intestines or brain or bone, everything is possible, right? So all those specific interventions also will be there. And if we don't treat TB, a full-blown case, if untreated, 50% will die. So just to tell you that, in rabies, for example, right, that has a case fatality rate of 100%, right? So TB and the human body at some point of time like to coexist, and that is why you'll see latent TB bacteria for life can remain in our body. It may never break down to disease, right? So there is that angle of tuberculosis infection and disease. Next slide, please. So the national program has been implementing over the years. Dr. Prasad has already spoken on. We can go to the next slide, please. Yeah, in terms of incidence reduction, we have been able to achieve 21% reduction in incidence, 25% in mortality, but we have a long way to go. We still, the reduction that we have been able to do so far from the SDG baseline from 2015 is almost twice the rate that decline is happening globally. But still, that is not enough. Look at this. We have to reach 80% reduction in incidence target, which roughly comes to around 47 per lakh population, and we are at 187 per lakh population today. Like that, for mortality, we have to reach 3 per lakh population, and we are at 21 per lakh population. So very clearly, there is a lot of work that is left to be done in TB, and that requires a lot of aggressive approach. Next slide. In terms of the strategies that the program has taken, you'll see that the sheer numbers, the size, 25-28% global burden we reached there. But there also is an angle where you can see on the bottom of this, right, that almost 90% plus 97% of the budgetary resources that are getting implemented in TB across this country is coming from domestic resource. We are not dependent on partners or any other overall donor funding agency to drive the TB program implementation in India. And that is the reason why we are able to do very aggressive approaches in handling TB. Can move to the next slide. So the structure, the program started way back in 1962 as a national TB program, and then has evolved over the years, right? And you'll see that in 90s when we started, in fact, as a formal national program by the government of independent India, started in 1962. Prior to that, in 1930s itself, TB was was being implemented through what is now called as TB Association of India. It's a civil society driven approach, and that one was way back pre-independence era, right? And then in 1990s, newer regimens came in, chemotherapy came in, and then the revised national TB control program was introduced, scaled up across the country over 2005 to 2011. 12 to 17, a very strong and ambitious strategic plan started being prepared. 12 to 17 and 7 to 17 to 25, when the words called as elimination started being used as the first time. Otherwise, it was always TB control. Let us find and put people on treatment, control TB. But 2017 onwards, with this government, which after the achievement of MDGs, decided to go very aggressive on SDGs and try and achieve the SDGs ahead of the global goals. So that's why you'll see that this program name also changed, the strategies have changed, and now it's being implemented on a mission mode, like Dr. Prasad said earlier, right? As a TB Mukh Bharat Abhiyan. This is getting implemented since last December. Next slide, please. So in terms of the strategies on ground, see, there are key strategies is to one, find all TB cases, put them on treatment so that they don't transmit to others, right? Second is make sure that we don't let a TB patient die, reduce TB beds, finish, make sure that we reach zero TB deaths goal as this. Third is anybody who has the bacteria inside the body, but we don't want them to break down to TB disease. So you prevent new cases from occurring. And all these three key ones, the cross-cutting theme is Jan Bhagidari, which is to take everybody, because like all of y'all are aware, the determinants of TB is poverty, undernutrition, socioeconomic conditions, living conditions, the density of population. So all these determinants of health, which is beyond TB or health, I would say, active just beyond the bacteria, the vulnerability of an individual, be it the substance abuse, smoking, tobacco, alcohol, or be it any disease that can reduce the immunity of our body. So that's why TB is actually called as an opportunistic infection. It will find the opportunity to go and break down to TB disease and multiply in the body, right? So that's the key strategies macro level, is to find all cases, put them on treatment, make sure they don't die, make sure that we prevent the next case from occurring, and we involve the entire society in this approach to address tuberculosis. Next slide. So with these strategies, now at the primary care level, right, when we want to screen, when we say screening, what do we do, right? Is to find all TB cases, right, as early as possible. Now, TB, you'll see that in the Abhiyan, one of the learnings was that a large amount of TB starts becoming infectious even when it is in the asymptomatic stage, right? So people are spreading, but there are no symptoms. They don't have cough, they don't have fever, they don't have any hemoptysis, they don't have weight loss. It's just subclinical infection where the bacteria started multiplying, and through normal breath we keep spreading it, right? So that is asymptomatic TB. So before we have frank symptoms coming in, so the focus of screening, active case finding, is to catch these cases early, even in the asymptomatic stage, and we make sure we put them on treatment so that we break the chain of transmission. If you find all TB cases in the in the community, put everybody on treatment, then the spread will break, right? So that is the objective for early detection. And so what evidence has shown us, what prevalence survey and multiple studies have shown us, is that 80% of the new cases is coming from 20% of the population. And this 20% of the population is what we call as the vulnerable population. It includes people who have past history of TB. So any person who has had TB in the past has almost a 25 to 30% higher chance of once again getting TB, getting relapse or recurrent TB, right? Contacts of TB patients, if somebody else in the household has TB case, their chances of they breaking down also to disease is very high. So they fall into the vulnerable category. Elderly, above 60 years of age, undernutrition, those with BMI less than 18.5, substance abuse, smoking, alcohol, disease which compromises on our immunity like diabetes, HIV, and then there is transplant, dialysis, all these cancer patients on cancer treatment. All those things are something which make the individual's immunity go down, and that's when TB as an opportunistic infection starts coming forward. So this vulnerable population is the key focus area. So if I am a CHO or I'm a medical officer at the PHC or a sub-health center, what I need to do is in my population, make a line list of this vulnerable group, right? Find out these 1, 2, 3, 4, 5, 6, 7, 8 categories, right? So identify these lists, make sure there is line list, look for TB among them. When I say screening, you get X-ray as a screening. This is where the tool helps us find TB even if symptom is not there. Early shadows in the lung, the pathological and the physiological changes in lung start coming by appearing as shadows in the X-ray. And that's why X-ray is now getting once again back into our system as a very, very important tool for screening at the community level, be it outreach based or in the health facility, right? So this vulnerable population, get the list done. As a primary care provider, I need to have the list of those people from where my next TB case can come. Second is the condition in which people are living in, right? The density of population. So you'll see that these congregate settings and workplace settings. So in these places, we look for all people who are living or working in these areas, get them to screen, even if they don't have the vulnerable criterias as I've spoken about in the previous section, right? So even if they don't fall into the vulnerable category, but somebody is working, living, or staying in this old age home, orphanages, slums, prisons, asylums, night shelters, mines, working there, brick kilns, construction sites. So these are all occupation settings that make that setting itself makes an individual vulnerable, right? So in those places, all we need to identify. So as a medical officer in the PHC area, I need to know where are my brick kilns, if there are mines there, where is my residential settings where people live in high density, right, or congregate places. Once you know your area, then you just make sure everybody there is screened. So your next TB case is either going to come from this vulnerable population or is going to come from this setting, this congregate and workplace setting, right? So that's the place from where you can find TB case early by going there proactively and doing active case finding using an X-ray. Whatever person from that X-ray is abnormal or who also has symptoms, their sample is collected and tested through a NAT machine. I'll come to NAT and diagnosis in the subsequent slides, right? So that is what we call as active case finding as a screening strategy in the primary care setting that can be done. In addition to that, what we call as passive or intensified screening, right? So this is when people by themselves are coming to our health facilities. So in those health facilities, routine OPD, we have people coming in. What our evidence says is that any adult OPD, routine general OPD, we find around 4 to 5% who are chest symptomatics, who have cough, may not necessarily be TB, chest symptomatics, right? They have cough, cold, fever. Go to any OPD and open the register, OPD register, cough, cold, fever, cough, cold, fever, cough, cold, fever, right? So you have these people who are coming in, but if we miss diagnosis of TB on them, we delay diagnosis on TB on them, they will go back, continue to spread. They'll come back to you after 15 days, 20 days, 1 month, we'll end up having them as TB. So in routine OPDs, make sure that any chest symptomatic or this diabetic person coming for routine follow-up, HIV person coming for routine, right? So any other vulnerable category person coming for our hospitals for routine collection of medicines or health checkups, make sure you do not miss TB screening out there, right? Second is there are certain OPDs which make these individuals vulnerable, like these NCD clinics, the cancer OPDs, ICTC, ART centers, dialysis OPD, where the people who are attending these OPDs already have a compromised immunity. There, make sure everybody. So let's make sure that everybody out there is screened for tuberculosis. So this is active case finding in the community, passive case finding in our routine OPDs, intensive case finding in specialized OPDs. So this is the case finding strategy that we will have a look at. Next slide. Right. So while we do this screening, we find people. So we identify, collect sample for testing. How do we diagnose now, right? So X-ray is used as a screening tool. X-ray we don't use for telling that basis X-ray only that this is TB or not TB. It requires a clinical diagnosis, a clinical opinion. Basis that Dr. Rajendra Prasad, like I mentioned earlier, also has multiple lecture series on how to read an X-ray. He has multiple books written out there. He has shared that in the previous one. So when the presentation is said, go have a look at those lecture series, which will help a medical officer in the primary care setting with the X-ray available in his hand, whether this is TB or no, it will help you identify that, right? So once that is there, the sample that is collected, right? So those people, the program now is saying upfront molecular diagnostic, right? Which means that we use CBNAT or TrueNAT. These are the two different technologies that I use. The technology is nucleic acid amplification test, NAT machines, right? So the sample is collected either in a sputum cup or in a falcon tube, right? You'll see the pictures on the right side. This sample is collected and then it is then used for diagnosis in these laboratories, CBNAT lab, TrueNat lab, or PathoDetect. That's another new technology that has come in, right? So the periphery level may not have these machines. These machines are largely available at the block level in the CHCs, right? So if there is PHCs or in the community sample is collected, it needs to be packaged and transported to the NAT site for testing. So there, why we choose NAT over microscopy is that microscopy is a manual one, right? The sample needs to be prepared as a slide, looked of stained, and then looked into a slide, and then the manual eye needs to find those red bacilli, acid fast bacilli in the slides, right? So that's a manual one. So the sensitivity of that tool is around 50%. So this nucleic acid amplification test, the sensitivity of these tools are as high as 98, 99%. So that is why NAT is the primary tool for diagnosis now, and that's the way the program is going forward to, right? So once somebody is diagnosed as TB, the NAT will tell also that whether this is resistant to the primary first line drugs or no, right? So rifampicin and INH are the primary first line drugs, and the NAT machines will tell whether this is resistant to rifampicin or no. If it is resistant to rifampicin, then we look for the resistance pattern for other drugs that is there in the quinolones and in the injectables, and that's where the line probe assay and the liquid culture drug susceptibility testing laboratories, these are BSL-3 labs that are there in the medical colleges under the program. You'll see that those are getting used. So sample needs to move there. That will get tested, the cultures will grow, and you'll get to know whether there is resistance for the other drugs that are used in the TB treatment regimen. But we do that only for those which are resistant in the TrueNat and CBNAT tests, right? So it's a serial testing, right? Next slide. So this is how we diagnose TB and make sure that the notification of TB is mandatory in this country, both for public and private sectors, right? This is very, very important that even if somebody in the private, it's a chemist who is giving drugs to a TB patient, it's a laboratory which is received a sample, tested and has identified it as positive, or a doctor in the private side, if he is initiated somebody on TB treatment, all of them have to mandatorily notify that to the system. They can give it manually to our any public health hospital doctor and he will notify for them, or they can all themselves log into Nikshay and notify. Both options are available with that. So that is a gazette that is applied. There are some places, so there is false diagnosis of TB. There were Purana, old times serology. So that was banned in 2012 itself, that serology, there are some places where in the private sector and illegally there these tests are still happening, right? So these are something which is discreet. Nobody can diagnose TB disease by a blood test in this country, right? So that's the bottom point you need to remember and keep in mind. Next slide. Right. So this is the integrated diagnostic algorithm, although it will look very complicated, but this is like for everything. What this is a summary of Dr. Rajendra Prasad's entire session of how somebody comes in, becomes drug sensitive TB or drug resistant TB, what happens to him, which regimen he'll fall into, right? So this is there. I'll simplify it in the next slide in terms of what it is. But anybody whom we test for TB, we collect two samples, test for first line drugs, right? INH, rifampicin. If it is resistance, then tested in line probe assay and culture for the remaining ones, and there the regimen. So what basically is that in TB, the treatment for the patient is individualized. Based on the resistance pattern of the individual, the patient is put on treatment, right? So that is the summary of this algorithm. Next slide. So for drug sensitive TB, right? So which is largely around 98%, 97% of the total TB cases in the country are drug sensitive TB, right? So in this treatment regimen is for 6 months. 4 months is continuation phase, 2 months is intensive phase. So in the first 2 months, the combination of drugs is HRZD, right? What it means is INH, rifampicin, isoniazid, rifampicin, pyrazinamide, ethambutol. So it is given as a fixed pill, as a 4 FDC. All these 4 drugs are there in one tablet only. And based on the body weight, you'll see that here on the right side in the table, right? So based on the body weight of the person has to take 2 tablets or 3 tablets or 4 tablets. But all these 4 drugs are there in a single pill. That is why it is called a FDC, a fixed dose combination, right? For pediatrics also that is available. But in pediatrics, ethambutol is available separately as a dispersible one, and pyrazinamide, INH, and rifampicin is available as one, right? So both are available in dispersible forms, and that is also there. So 6 months, 2 months, 4 drugs, and after that for 4 months continuation phase with 3 drugs only: INH, rifampicin, and ethambutol. That in a single pill, based on the weight of the patient, the number of pills have to be taken. You'll see the pictures of how the blister packs of 3 FDC and 4 FDC. What 4 FDC means? 4 drugs in a fixed dose combination. 3 FDC means 3 drugs in a fixed dose combination. So the 4 drug combination is used in intensive phase, 3 drug combination is used in continuation phase. Next slide, please. So for the drug, this is for 98% of our patients. Straightforward, simple, 4 months of continuation phase, 2 months of intensive phase, 6 months treatment. Now complication starts when somebody becomes resistant, right? So for that also there has been a lot of advancements. The details have been taken by Dr. Prasad already. But what happens is when we test, right? We do a NAT test, we get to know TB, and then we get to know whether it is resistant to rifampicin or no. So if it is resistant to rifampicin, then on the right side, right, we go and put them on the appropriate regimen for that. The left side, if you'll see that rifampicin is sensitive, but even then it could be resistant to INH, which is another one. So we do a INH cut test, which is called the first line LPA, line probe assay test, right? So we test that, and so the 2 samples that we collect, if you'll see in the previous slide, right? So one sample goes to these labs, one sample goes to the NAT side, and you get to know the resistance pattern. So if it is resistant only to isoniazid and sensitive to rifampicin, then there is a H monopoly resistance on the left side, the box that is there, which is for 6 to 9 months, right? Now, if there is resistance to both INH and rifampicin, then it falls into the category of multi-drug resistant TB or RIF resistant TB, RRTB, right? MDR RRTB, right? Now that and the other first line drugs, right? For fluoroquinolones and second line drugs, if there is resistance, then it falls into a subset of pre-XDR, XDR, right? So these are the categories of TB patients, and the treatment regimens for these resistant cases. Treatment of choice now, first choice is a shorter regimen called BPAL-M regimen, which Dr. Prasad also mentioned about: bedaquiline, pretominide, linezolid, and moxifloxacin combination. It is given for 6 months. In some cases, extension of treatment is given, so it can go up to 6 to 9 months. Then there is the shorter oral. These are older regimens, but still a proportion of patients fall into this who become ineligible for any clinical reason for the BPAL-M regimen. If they are not eligible, then they need to be given shorter oral, but all oral regimen for that, with again a combination of drugs, which was there in the previous slide. That goes up to 9 to 11 months. And then the longer regimens, which can go up to 18 to 20 months. So you'll see that when somebody becomes resistant, that 2% case, but the treatment becomes very, very complicated, and the program is providing all these different regimens, different drugs, free of cost for the patient, right? So you'll have to keep in mind what is there, because these patients are getting diagnosed at the higher level. So you just have to make sure that you know the warning signals, and you know that how long a treatment goes on. The doctors will keep telling you from the higher side at the DRTB center till when the treatment needs to be done. Next slide. So when do we follow up for these patients also, and the public health action? So because this is a public health program, so yes, there is a patient, right? Now for that patient, there are certain public health actions that are required as a public health program, right? It is related to the patient himself, and it is also related to the contacts of the patient. That is why it is a communicable disease, right? So that is why these ones. So counseling of patients should be done. Drug susceptibility testing, finding out the resistance pattern so that the patient is on the right treatment regimen. That needs to be done. HIV testing needs to be done for identifying comorbidity. Blood sugar testing. Differentiated TB care is a newer one where we prioritize TB patients. Like you identify a high risk mother or a high risk pregnancy, and then make sure that there is institutional delivery. Similar to that, a high risk TB patient, one who has certain vital signs in terms of pallor, icterus, edema, pedal edema, respiratory rate, fever, weight loss, inability to stand, eat food. So the sick patient, clinically sick patient, we try to identify them, admit them if required, but make sure they are taken care of. Right. So that is called differentiated TB care. Monitoring treatment for the entire course, adherence again is a very important aspect of TB. Giving the nutrition benefits, be it the cash benefit through a direct benefit transfer under Nikshay Poshan Yojana, or in kind food baskets that are given by a donor called a Nikshay Mitra. For the contacts in that household visit, the CHO, the medical officer, the ANM, ASHA, the outreach teams, public health teams of us should go to the patient's house, look at the contacts who all are living there, get them to the hospital, screen them, get an X-ray done, rule out active TB, and then either they are put on preventive treatment. If they don't have active TB, if they have active TB, they put on active treatment. Right? So that's how it is there. So basically, once a doctor has identified treatment started by a doctor, identify as a primary care provider, identify who is going to give treatment, because treatment is to be monitored daily, dots, right? Directly observe treatment. So identify a treatment supporter. Could be Asha, could be anybody else in the community. Once you identify that, let the treatment medicines, the drug boxes, the strips be with the treatment supporter. They should go and give it to the patient daily, right? In front of them under supervision. Make sure that adherence and patient support, whatever is required, is done. Monthly, once in a month, at least a medical officer checkup is done. And we do this until the treatment regimen is completed and the patient is successfully treated. Next. So these are the public health actions that we need to do. The nutrition interventions, like I said, Nikshay Poshan Yojana, which is a DBT of 1,000 rupees per month. Energy dense nutrition supplement is a new one that has been started, in which it is like what we give for SAM children, right? In the nutrition, these nutritional supplements are added for 2 months along with the drugs. This is also given when the patient is having a low BMI. If the BMI is more than 18.5, this is not required. Nikshay Mitra, like I said, donor support, but monthly nutrition kits to be given to the patient and the family so that the nutrition of the household is taken care of. Next. So as a primary care provider, you need to make sure that these nutritional interventions and public health actions are taken care of. And then every month there is a clinical follow-up. During follow-up, lab investigations may be required. If somebody is pulmonary TB, had a sample, a sputum positive test, then at the end of IP, we need to repeat it. Monitor progress, right? X-ray needs to be repeated. At the end of treatment also, try and get a sample and do culture, or X-ray needs to be done for follow-up. After treatment also, the TB patients need to be followed up every 6 months. 6 months, 12 months, 18 months, 24 months. Why are we doing this under the program? Is because the evidence has suggested that the probability of the patient, when I said, if you remember, right, in the vulnerable group, 25% of the patients come back to us with TB. And the person who needs to come back to us with TB comes to us within the first 2 years of treatment completion. And that is why under the program, follow-up of TB patients is recommended at 6, 12, 18 and 24 months, right? So this is the follow-up protocol that we need to follow. Next. So TB preventive treatment again. So for all those household contacts, PLHIVs and the vulnerable population, right, that we now have, we do an X-ray, see whether they have TB or no. Doctor then sees normal X-ray, clinically sees there is no other symptoms, decides no, there is no problem with the active TB. Then we can put him on preventive treatment. Contacts also, right? So different states have different policies. Somebody in some states there is treat only policy, which means that they will identify the contact or the vulnerable person, do an X-ray, clinical examination, and then decide, okay, there is no active TB, so we'll put them on preventive treatment. In some places in this country, the state has decided to do a IGRA or a CYTB test, which identifies TB infection. And if it is positive, only then they are put on preventive treatment. So there is mixed policies that the states have adopted in this country. So this is the algorithm. Having said that, whatever treatment needs to be given. So there are multiple treatment regimens for preventive treatment also available under the program. 6H, which is 6 months daily isoniazid. This was given long back, And now this has been replaced with 3-HP, which is the newer drugs of INH, isoniazid, and rifampicin combination to be given once a week for 12 weeks, right? That is 3 months. So you'll see the difference between 6H and 3-HP, right? One pill every day for 6 months versus once a week for 12 weeks. So that is why 3-HP is the preferred choice of treatment regimen that we give. 3HR is another alternate regimen. So technically there are multiple regimens available. For PLHIVs, the regimen is 1-HP, where this combination of INH and rifampicin. So this combination, rifampicin, sorry, is given for every day, 1-HP, which means 1 month of INH and rifampicin. 3-HP once a week. So in PLHIV, we give it daily instead of once a week, and we give it daily for 38 days, 30 days, so that the patient is taken care of. So these are different options of preventive treatment that we have under the program. Next. So all this is the last 2 slides on this. So under the program, as a primary care provider or from the front end, Nikshay is something where mandatory every TB case, every person who is tested for TB needs to be entered in. They are everything. This is a system where entire life cycle of the TB beneficiary patient is there. So right from his initial test for diagnosis of TB till diagnosis of TB, his treatment regimen, his post-treatment follow-up, all these things can be done through the same Nikshay portal, right? So all those investigations, reports, follow-ups, everything can be entered here only. And you can see all these things in reports and dashboards at all level, right? From the central, state, district, block level to the peripheral health unit level, right? So this is a unique system that we have across the country, and all TB patients means not just public sector. We have around 10 lakh cases in the current year that have been notified by the private sector. So you can see the reach of this system and the utility of this system. Next slide. So you'll see that, there is these login pages when somebody wants to register. Next, it's an animated one. Just keep clicking, So like that with different modules where you can see individual patients, treatment details, and then reports, dashboards, all those things also are available for you to see. Right. So this is in short, I think this is the last slide. So I'll stop here. Thank you. And on the macro level, in terms of as a primary care, the technical guidelines, how do I implement it? What is expected from me as a public health, officer in the community? This should help you implement it better. So I'll stop here and open to questions. Yeah. Thank you.
Thank you, Dr. Raghuram Rao, for your elaborate presentation on TB program, and also touching the technical part, how do you diagnose and manage, what are the common problems seen. There are few questions. Dr. Rajendra Prasad is also here. Um, there are few questions in the chat box. Maybe we can take this one by one. There is one question on, in latest guidelines, sputum smear is not done, then how can we detect non-tubercular mycobacterium where AFB is positive and CB naught comes negative?
Okay. So here it is not that the non-tubercular mycobacteria is not detected if sputum microscopy. Sputum microscopy, nobody can diagnose whether this is Mycobacterium tuberculosis or non-Mycobacterium tuberculosis, right? So there are different, cultures and tests that we do for sputum, sample that is collected both in NAT and in the cultures that we do. We are able to identify non-tubercular bacteria. The sputum microscopy test is recommended not for primary diagnosis of TB, but it needs to be done for follow-ups. You cannot do a NAT test as a follow-up test, right? Because there will be false positive, because it is a nucleic acid amplification test. It detects even the artifacts. The dead bacteria also will be detected. That is why NAT is not done for follow-ups. For follow-ups, we use sputum microscopy, and for the tubercular bacteria, we still do, the primary tool for diagnosis remains NAT machines only, CBNAT or TrueNAT. So even if the AFB sputum smear is positive, if CBNAT is negative, then if the clinician suggests that this is non-tubercular mycobacteria, then there are other tests that are required to be done and alternate treatment regimens that are available, right? That needs to be taken care of.
Okay. I somehow cannot switch on my video. Something gone wrong. Maybe. Okay. There is another question. I think if AAB is positive, CB naught is negative, but LPA is positive and shows no resistance, how do we go ahead in such situations?
Yeah. So whenever there is serial testing, there will be discordance of two different technologies that will come in. So an umpire testing is done where a third technology. So if the final one, LPA, right, and sputum, AFB is positive, means sputum is positive, then that is definitely positive. That is the most strongest tool because you're actually seeing the bacteria in the eye, right? CBNAT, if it's done on artifacts, if it is done on CBNAT negative, so there are very very few cases. These are outlier cases that we see in the program where there is discordance that happens. So a third technology, a higher level test, and a culture is considered as the gold standard, where we then the laboratories, the intermediate reference laboratories that we have in the states will finally give a diagnosis, right? So there will always be these scenarios of where one technology is saying positive, a second is done. So a third test, an umpire testing is done, and then the clinician decides based on the umpire testing.
Okay. Uh, there was also one question about cut ADA. Can you use ADA as a test for confirmation? And what is the cutoff point for that?
Yeah, so that is not as part of the guidelines, not recommended for this thing, for only for the reason that ADA can be positive for multiple other reasons also. That is why serology itself is banned, like I told you earlier also in the presentation, right? So it's only because of the very high false positivity that we can get, and there is a very high chance that somebody will be labeled as TB, put on treatment when he is actually not happening. So TB has both overdiagnosis and underdiagnosis. That
Yeah.
that risk always remains, and that is why it's a very difficult disease to treat and diagnose also, especially when it is extrapulmonary, where ultimately when no other test comes positive, the person is put on trial ATT, and then if he's responding, then it is said, okay, clinically diagnosed TB. So that is also a scenario in this country. So the recommended ones for TB diagnosis is a molecular test, and through a CBNAT or a TrueNAT or a histopathology test, a gold standard culture test, right?
Thank you. I think the message is very loud and clear. Don't use IGRA, TST for diagnosis.
Correct.
Yeah, don't use it. Many people are using it for diagnosis. That's the wrong approach. It is the AFB sputum and the CBNAT and then LPA umpire test. I like this term, umpire test. And there is another question on uveitis, IGRA positive, referred by an ophthalmologist, no clinical symptoms. What should be a physician go ahead with?
Yeah, so same case answer. IGRA positive does not mean TB disease. What it means is TB infection. Right. So clinical rule out of active TB needs to be done. So get an X-ray done, look for other sign symptoms, and then if not, then if the person is not vulnerable, then there is no need to do anything. If it is positive, then we can put them on preventive treatment. Right. Like I told you earlier, case fatality rate of TB untreated TB can be as high as 50%, which means that there is self-resolution also that happens. The lifetime risk of somebody who has a TB infection in the body, which means if I test myself, I have TB infection, I'm IGRA positive. My probability of breaking down to TB disease lifetime risk is around 10% only. No? But if I have diabetes, if I have some other immunocompromising condition, then my probability of breakdown starts increasing, becomes 20-30% higher, than a normal person. That is why if this person is, and it's an ophthalmologist, a uveitis, which means there is infection out there. So just correlate clinically, look at other vulnerabilities. If not, just take care of the uveitis. No need to take care of TB there because it could be self-resolving. Only if it is, there are other signs and symptoms of TB disease, then you start TB treatment.
Okay. Uh, then I think you've all the aspects of TB have been covered. But many patients develop jaundice on ATT. When they are put on ATT, and some of them do not tolerate it also because these drugs need to be take empty stomach. So, what is your advice? How should these patients be managed?
Yeah, yeah. I'll pass this question to Dr. Rajendra Prasad, who's been handling TB patients clinically for the last 40 years. He's been teaching also. Yes, sir. Okay.
Thank you, Dr. Raghu. And yes, I agree that in some of the patients, when you prescribe anti-TB drugs, about 5 to 6%, maybe up to 5, not everyone, may get a liver toxicity. Liver toxicity in terms of patient usually complains when you prescribe these drugs, loss of appetite, and some yellow color in the eyes, then you get LFT done. How we react as a clinician? So suppose somebody has developed this, and you did LFT, and in LFT you find that if the serum, aminases, SGOT, SGPT, they are rise more than 3 times. Some of the guidelines say 5 times, but 3 times more than this, and he's asymptomatic, means loss of appetite, and then nausea, vomiting, and then, or if he has serum bilirubin more than normal, more than 1.2, then it means he has developed some hepatotoxicity. In hepatotoxicity, what you have to do is to ideally, if the patient is not very sick means TBM, where a TT is very essentially required. There you ideally we stop anti-TB drug for about 5 to 7 days, and then we repeat. Usually all the patients they improve when you stop all the drugs, and then you can restart these drugs when LFT and symptomatic improves, enzyme levels get down, then you can restart. And the restarting of a drug, there are 2 ways. One is American Thoracic and another is the British Thoracic Society. And we are also doing like this, that once you start the least hepatotoxic drug first, say ethambutol is the least hepatotoxic drug, and then initially when you use streptomycin, that is also not a hepatotoxic drug. Now usually it is not used. And then the levofloxacin is also least. So you can start 2 drugs at minimum, and then you follow the patient, and patient improves, and LFT also improves subsequently. Then you can reintroduce further drugs. The first drug to be introduced is rifampicin, because if you have been able to use rifampicin, then this is going to be a shorter regimen. And then if he tolerates rifampicin, you may reintroduce even pyrazinamide. That is how we do in most of the cases. And most of the cases they respond and they tolerate. And most hepatotoxic drug out of the primary 4 drug is the pyrazinamide. So many times pyrazinamide they are not tolerating. Suppose you are giving 3 drugs from the beginning and a continuation phase, then treatment may not be for 6 months. Maybe they have to prolong for 9 months. That is the basic difference. That is the basic. The changes what we make as a clinician. And believe me, it's not a very bad side effects, adverse drug reaction. Many of them they re-tolerate these drugs, but you have to have patience and have to advise your patient, have to counsel your patients. Then let's say that this is how we react to the adverse drug reaction to liver.
Sir, how often should the LFT be done to see whether the patient is recovering from this hepatotoxicity?
If patient is recovering, then the LFT may be repeated between 7 to 10 days of time.
Okay. Sir, there is one question about use of tuberculin test for diagnosis in pediatric age group. I think.
Same thing, same what Raghu has said. These tests are not for diagnosis. These tests
Yes.
are for knowing the infection. But
Yes.
anyhow, in a pediatrics where you are not very clear about, now I'm talking as a clinician, that if you are in doubt and you are doubting that it could be TB, and if the IGRA or Mantoux test, a tuberculin test, what you call, is highly positive, you can sometimes treat the patient presumptively, but you have to tell your patient it is not the clear-cut diagnosis. It is on presumptive ground. If you agree, we may prescribe. So that's why. Otherwise, there's hardly any role. I totally agree with Agman that these tests are not useful as far as the diagnosis of tuberculosis is concerned. That's very clear statement.
Sir, there is another question. When should CBNAT be done in a patient who has past history of ATT intake, as there is a possibility of false positivity? Any time period mentioned where it can be done?
I think in old cases of tuberculosis, where you are follow-up tuberculosis, Dr. Raghu was very clear in the statement. These tests are for initial diagnosis. Subsequently, follow-up, these tests are not done. Patient who has taken previous treatment, usually they are not done. If you have done it, treat this just very, very cautiously.
Also,
It's an
the
individual approach.
follow-up test that is recommended in the guidelines is a microscopy and a culture.
Yes.
Post-treatment follow-up, right? So
Post-treatment follow-up.
those are
Not-
the tools which you can use for diagnosis and not CBNAT.
Because false positivity would, because this test will remain positive,
Exactly.
so that is why it is
Yes.
not done.
And there are, somebody asked for the cutoff. So there are evidences that the artifacts remain for as high as 1 to 2 years, in the body. And therefore, for follow-up for 2 years that we recommend under the program, so the recommended tool is microscopy and a culture once in 6 months and not CBNAT.
Okay, there is one question on, can we perform a dental filling, any dental procedure where aerosol is generated in a family member of an open pulmonary TB patient on ATT?
Yeah. The family member means you do not know whether this person has TB or no. Second, you do not know any patient that is coming onto your dental chair whether this person's family member has TB or no. So the answer is universal precautions. Right? So for assume that every patient that you have on the table is an infectious case and could be having TB, could be having HIV. So any procedures that you do, make sure universal precautions are followed. Mask is worn, gloves are worn, apron are worn. All this is for precautions. So do not deny service to any patient just because their family member was an open cox on treatment. And secondly, the person who is infectious in tuberculosis, within 2 to 3 weeks of treatment, the person becomes non-infectious, right? So the person is on treatment for more than a month, even for that person also, any treatment that is required should be given. So it's basic thing that universal precautions have to be followed by every healthcare provider, be it a dentist or a surgeon.
Thank you. Sir, if suppose this is regarding nutritional supplementation, you have extensively covered that. But suppose if the patient has come, TB patient is also having anemia, you know,
Yeah.
should iron be started immediately, or should
Yes. So when I said differentiated TB care approach, right? When in the slide I mentioned that. So all these people who have HIV, who have diabetes, or who have, there are uncontrolled diabetes along with TB, then to shift from oral antidiabetic drugs to insulin dependent drugs. So all those changes. So the physicians who are managing these case and comorbidity along with that. So giving whether it requires a blood an FFP to be given to the patient, a blood replacement, or an iron folic acid supplement, injections, oral, or all these things, whatever is required needs to be done. You know, this
Sir,
comorbidity has to be managed. Yeah.
if the patient is on INH, do they need any supplementation, special vitamin supplementation?
We give, there is, pyridoxine that is given, but we give that in the program currently only for those who are on treatment and who are PLHIVs, but not
Okay.
for all, but prescribing because it's available in the general system, multiple, B complex drugs are available in our system, so it can be given. Yeah.
Does TPT increase the risk of drug resistant TB?
Now, so there has been enough, research across the world on this, and the 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 public health choice of giving a drug, and mind you, it has now moved from a monotherapy where single 6 months INH was given to a combination of two drugs, INH and rifampicin, as a preventive treatment. But the risk of developing resistance towards the benefit that the patient may get, the benefits outweigh it very, very hugely. And that is why it is recommended under the program. But there is very, very minimal theoretical risk that somebody may, develop resistance.
Okay, thank you. Dr. Rajendra Prasad, this question is for you. Linezolid induced neuropathy management. सर आप अनम्यूट कर लीजिए.
It induce, isoniazid is a very common drug. Then linezolid, sometimes ethambutol. They are rare. I mean, the first thing, it is very rare tox. It is not very common. But to prevent, usually better is to prevent the neuropathy. And for a prevention, the pyridoxine is already in the program. Their supplementary pyridoxine is given. But suppose once one has developed neuropathy, then the drug is the same pyridoxine, but the dose about 200 to 400 milligram dose has to be increased. But this is not very serious adverse drug. Only with linezolid. Linezolid is drug which is used in the MDR and pre-XDR or XDR TB. Peripheral neuropathy is one of the side effects which is sometimes troublesome, and there also they advise the similar outcome. First, the dose is reduced, and if by dose reduction and some supplementary vitamins are given, if they are not working, sometimes you have to change the regimen and to replace the drug. That is how we react to peripheral neuropathy.
I think that answers the question. I think ATT induced liver injury delay has already been answered. The question is not very clear. The next line of management, I think the message was quite clear. If you could stop for few days, stop ATT, and then reintroduce these drugs one by one, so that you know which one is it causing. And most time it resolves, it does not come back again, so need not worry about that. Only thing is that during this period you need to follow up this patient and reassure the patient that this is side effect which will can be tackled, will pass with time. I think that's it. Anything would you like to add, Dr. Prasad?
No, that's all. I think you have got, as I said earlier, this is your first program in this series. So you have made me and even Raghu Raman also as in a Sunil Gavaskar of the team, right?
I mean, we have two, lead batsmen with us. So why not have the utilize that opportunity? But I think considering the TB, the size of the problem, and the variations, challenges that we come across, it is very important. Even if we have this every year, this topic, it won't be enough. You need more to do about this.
Yes, yes,
Again,
Dr. Sangeeta, I have already said that education in TB is a very, very essential component. Although government is doing a lot of education in TB, but still, I personally feel that more and as you said, Sangeeta, whenever I take a lecture on TB, less time I take, more time I spend on the answering the question and answer. And
I know.
and usually I love that because I believe with the so much of seniority in this area, I believe I must spend time and must educate the doctors, even the community. That's why I said I will repeat. I had a YouTube channel. For what Dr. Raghuram has also touched, I have a YouTube. People are now started calling me YouTuber because one of my lecture on X-ray on YouTube, how to read. I was just teaching to the MBBS students, and that was recorded, and I put around 380,000. I mean, people have viewed that lecture. Since then, people have given me another nickname, sir. Now you are a YouTuber. So lots of
True.
postgraduate, undergraduate student, lot of doctors, they follow me on the YouTube. That's why I said, if somebody can wanted to subscribe, I have very simple Rajen Prasad KGMC. If you could, you'll go to my YouTube channel, and there are a lot of, there are more than 250 lectures there, and all are educative, either to the community or to the doctors.
Thank
So
you,
there,
sir. Thank you very much there. I think your bottom line when you closed your talk was you're never too old to learn, and the more you learn, the
Yes,
younger you become. And
yes, yes, yes.
yes, you have boarded the uh, flight of Gen Z, millennials, Gen Alpha, Gen Beta. You are ahead of them on in their own race. And that's fantastic to see, sir. That's fantastic to see. I'm afraid my team tells me that we are coming to the end of this session. But before we go, a few things that I need to sum up here. One is the number of people who joined today. It was the first session of this fourth series. The number of people who joined today was a record high. That shows the importance that people attach to this subject. And there was attraction. And the number of people who stayed on through it, throughout the 2.5 hours that we were together, shows how magnetic our experts were in holding the audience together here. The way you have covered it, sir, um, it has addressed the experts as well as the novice, the super specialist, as well as the MO sitting in the PHC, as well as the CHO. I'm sure everyone found it equally easy to digest. We covered areas of the importance of detection, asymptomatic screening, vulnerable screening, and what was said in the first session as well as in the second session is it's a whole of society treatment. It's not just a doctor's role. It's a whole of society. Everyone needs to come together to fight tuberculosis. And in this age and day, there is no reason why someone should die from tuberculosis. Modalities are available for early diagnosis. Modalities are available for treatment, for multi-drug resistant treatment, and so many options are available. And modalities to make the treatment safer for the patient are very well embedded. Uh, one thing where we started, and I think it's a good point to end on also, is that not only the role of the doctors, the hospitals, the ASHAs, and all the public healthcare actions which are there, the Nikshay portal, the nutrition. We need to reiterate the treatment algorithms at periodic interval. So many examples you shared in the very beginning, which was a wake-up call, I think, for everyone, that doctors in hospitals, whether in private setup or public setup, are often found prescribing inappropriately. Various studies have shown this thing, that the treatment is not rational, not following standard treatment guidelines. And that's where the role of the STG webinar that NHSRC and Delhi Society for Promotion of Rational Use of Drugs, we come together to promote rational use of medicine. Um, there will be many more questions. Yeah. If audience has any questions, you can drop in those questions in our mailbox. We will take them with the experts. We will come back to you with the answers. All that's left now to do is for us to thank our experts, Padma Shri Dr. Rajendra Prasad ji. It was an honor to have you with us. Dr. Raghuram Rao sir, we know how busy you are in the Central TV division, and yet you gave your time to us and stayed on throughout this. Both our experts were so lucid, simplified everything for all of us. So thank you very much. Thank you, Dr. Sangeeta Sharma, for helming and anchoring and putting up important pharmaceutical and drug-related questions which keep troubling people, but they don't know where to ask them. And uh, finally, a big thank you to the team from NHSRC QPS division, Dr. Ranjit Mondal, who was organizing it all along with Dr. Shreya, who is also here with us, our administrative team, our IT team, which has supported the entire venture. With this, I wish you all the very best and thank you very much once again. Jai Hind.
Thank you, Dr. Patni, for taking up
Thank you.
this, continuing this series and providing all the support, back-end support for conducting these webinars. See you next time. What is the next topic, Ranjit?
Uh, first,
आपके एंड पे कुछ प्रॉब्लम है इंटरनेट में एनीवे नेक्स्ट
हो गया उनका
next session
very
is
interesting. Thank you. Yeah, it was good.
Dr. Raghu Raman, Dr.
Sir.
Raghu,
Yes, sir.
may I make a request? Can you send me this slide? You have made
I'll
a
do that, sir.
wonderful slide.
I'll do that, sir.
Uh-huh.
I'll share, sir. I'll share. In
Thank
fact,
you.
I think
Thank you.
the participants, it will be shared by the team, and I'll share
Yes.
it separately, sir. I'll WhatsApp.
Thank you. Thank you. Thank
Thank you, sir. Thank you.
you. Okay. Thank
So
you. Thank you.
next topic is on elderly care and palliative care basics and integrated elderly care at primary care. The date, can you tell me the date? It would be the third Saturday as usual. So please join us for the second session as well. I think this is another area which needs a lot of, there are gaps are there, and we need to, uh, upgrade our facilities to provide palliative care and elderly care. There are lots of issues around with that. Thank you. See you on the.
Thank
Thank
you.
you.
Thank you,
Thank you.
everybody. Namaskar. Jai Hind.
Jai Hind.
Jai Hind, Jai Hind.
गड़बड़ है। डिले नहीं इसलिए क्योंकि टेस्ट कर रहा हूँ।
टेस्टिंग के लिए।
ये सिस्टम ही इसलिए लगाया था क्योंकि ये एमपीसीसी में यूज हो रखा है।
कौन सा?
ये पूरा 8 आवर्स हमने कंटिन्यूअसली यूज किया।
फिर ये अभी क्यों नहीं ले रहा था? बस
चलो
काफी ये सेंसिटिव भी है, जैसे बहुत मैं आराम से बोल रहा हूँ।
नहीं, मैडम के पास तो मैंने ये भी भेजा है ना, तो एल्डरली वाला कहाँ से मैडम ने देखा?
पता नहीं, एक मिनट एनुअल फ्लायर देखने में तो सिकल सेल डिजीज भी है एनुअल फ्लायर में